I'm Jean-Pierre Bassand. I'm a professor of cardiology at the University of Besançon in France. Welcome to Stockholm. We are in Stockholm for the European Society of Cardiology 2010 meeting, and we'll be discussing the new European guidelines on myocardial revascularization. I'm joined today by three members of the task force who were in charge of writing these guidelines, and namely the two co-chairs, Philippe Cole. Philippe Cole is a cardiovascular surgeon and professor of physiology at the University of Liège in Belgium, and William Wijns, who was the second co-chair, is co-director of the Cardiovascular Center in Aalst, also in Belgium. And last but not least, we have also Sigmund Silber, professor of medicine in cardiology practice and hospital in Munich, Germany. So please, let's start our discussion starting with what is innovative in this new guidelines recently released at the European Society of Cardiology meeting in Stockholm. From my point of view, it's the first time ever that guidelines are written specifically on myocardial revascularization. In the past was on PCI, but not on myocardial revascularization per se. And to the best of my knowledge, it's the first time ever that we have a close collaboration for this purpose with two organizations which not necessarily in the past collaborated so closely, namely the European Society of Cardiology on the one hand, and the European Association for Cardiothoracic Surgery on the other hand. So Philippe Cole, you are the surgeon, welcome here. Would you please tell us what you feel is very innovative in these new guidelines?
Well, Jean-Pierre, I think that there are several key points that are innovative. First, as you mentioned, is the true collaboration between both scientific associations. And this was a very collaborative process that was built up in a very nice and thoughtful spirit. And throughout the discussion, we came to acknowledge the importance of the concept of the heart team. The heart team was actually developed and used in the syntax trial, and we thought that was a very appropriate way to discuss the case of several patients. Now, obviously, the heart team is a concept that is appropriate for several, but certainly not all patients. On one hand, you have what is called ad hoc PCI, meaning to do the procedure, the therapeutic procedure right after the diagnostic procedure. And on the other hand, you have the necessity to wait to discuss with the patient, to discuss in a multidisciplinary approach, and that's where the heart team appears.
William, would you please comment about also on the composition, the components of the heart team? Is it simply limited to the interventionalists and the surgeon, or should we enlarge a bit, have a broader representation of other component of our discipline?
Yeah, thank you, Jean-Pierre. This is a very relevant question. The concept of the heart team is that we like to put the patient at the center and bring at the bedside of the patient all the expertise that is likely to improve the outcome if people work together. So the heart team is not just about signing off indications, it's about agreeing upfront on protocols. It's not necessarily that there should be each time a physical meeting. That can happen at times for the more complex cases. But the heart team concept also entails that the group of physicians that's caring for the patient with coronary disease have agreed on protocols on how to approach a patient that presents with stable disease or an acute coronary syndrome.
I like particularly the comment you made that the patient should be at the center of the heart team. The heart team is for the patient, and that we should concentrate on the patient and the needs for being revascularized, etc. This is something that possibly was a little bit neglected in the past. We have to put back the patient in the middle of our preoccupation. Sigmund, you want to make comments about the heart team and formation, etc. And we mentioned also, you mentioned chronic stable angina. Of course, we have a lot of time to decide and talk with let's say talk about the features of the patient with the heart team in case of chronic stable angina. Maybe we can move on this issue, but you feel free to comment on the really innovative features of this guideline in terms of heart team and information to patients.
Yeah. Thanks, Jean-Pierre. I think the spirit of the heart team, especially for patients with stable coronary artery disease, is a real advantage for the patients, because sometimes, the patient gets a catheterization and then he gets two different opinions. The cardiologist says it's a clear indication for PCI, you don't need surgery. Then the patient goes to the surgeon says, well, maybe surgery is the better option. I think the spirit of the heart team is that in patients with stable angina, surgeons together with the cardiologist give a single opinion to the patient. So the patient is not confused anymore, and the patient gets a straight opinion what the best option is for him. For us invasive cardiologists, of course, that means, and this is also a part which we have written in the guideline, that in patients with complex disease, you should not step in ad hoc immediately PCI, but maybe stop the diagnostic catheter first and then talk to the surgeon and give the patient a final conclusion. So don't rush in complex cases.
Now, I'm afraid that time is flying quite quickly, and then we should move to acute coronary syndromes. And of course, we have two forms, ST elevation myocardial infarction and non-ST elevation acute coronary syndromes. Do you really believe, Sigmund, that there is much to say about ST elevation myocardial infarction in terms of procedural approach to the disease in terms of reperfusion?
Jean-Pierre, I think since the latest STEMI guidelines of the ESC are still valid, we have not changed much regarding STEMI and non-STEMI guidelines for revascularization. So the approach is pretty similar to the previous documents, but what's probably new in these guidelines is that you should first go for the culprit lesion. And if, again, a patient has a very complex three-vessel disease, maybe after doing the culprit lesion, you don't have to call the heart team for doing the culprit lesion. There's no time and no need. But after having dilated and stented the culprit lesion, then if it's complex disease, you still should set back and think twice and call the heart team for further procedures. And it's not so rare that after having done the culprit lesion, you still go for surgery at an interval.
You mentioned pharmacotherapy. Let's come to pharmacotherapy. Philippe, would you agree on the fact that in the field of anticoagulants there is not much to say? You are a cardiac surgeon, but you are very familiar with the drugs we use in the setting of percutaneous coronary intervention. I don't think that there is much to expand on in terms of anticoagulants.
In terms of anticoagulants, strictly speaking, certainly not. Maybe what should be mentioned is that for the first time in these joint guidelines, there is a specific chapter on antithrombotic agents that does include antiplatelet agents. And this acknowledges to some extent the importance of this part, and we have divided our recommendations according to the clinical presentation of the patient, stable, non-STEMI, ACS, and STEMI. And I think that our recommendations summarized in tables there are quite helpful and will be quite helpful for the physician at the patient bedside. Concerning more specifically antiplatelet agents, we are addressing for the first time two rather new drugs, namely prasugrel and ticagrelor, in acute coronary syndromes.
It's quite clear that if there is nothing much new for anticoagulation, the radar screen is quite busy as regards antiplatelet agents. We have now, of course, aspirin, but we have now three drugs or three different regimens: high dose clopidogrel, prasugrel, and ticagrelor. So how do you see the situation, Sigmund?
I think what's important, it's not only these are new drugs, but these are more reliable drugs. I mean, there was a lot of discussion within the last 1 or 2 years that there are clopidogrel responders and non-responders. Maybe there's a genetic response to that and all this discussion. And we are very lucky that we have two new drugs which are independent of this genetic order. So we do not have to do genetic tests to decide whether to give these new drugs or not. Plus, we know, especially for prasugrel, that it is much more reliable, and the onset of action is much faster than clopidogrel. And especially since timing is so important, of course, it would be important to give the patient an antiplatelet drug which is reliable and has a fast action of onset.
So the main advantage,
It's a fast onset of action.
The main advantage of the new drugs, new P2Y12 inhibitors, is that faster onset of action and much higher level of inhibition of platelet aggregation and consistent, let's say, action, less variability as compared to clopidogrel.
I think we also have a fantastic opportunity to improve outcome of patients with diabetes and acute coronary syndromes. I mean, patients with diabetes are patients in need by all means, and certainly their outcome with PCI procedures is suboptimal, and it can be improved with prasugrel. So I think that's a very important opportunity for us. The other option is that we recognize the negative impact of intracoronary thrombus load. And perhaps in the future we'll learn a lot from new imaging, optical coherence tomography, for instance, about how we can deal with those coronaries that are loaded with thrombus, and this is associated with poor outcome, including high risk for stent thrombosis.
Yes, I think that's very important. I mean, of course, we know for many, many years that thrombus is the problem in acute coronary syndrome, but in the new guidelines, we have put more emphasis on the thrombus load. So we have upgraded a little bit thrombus aspiration, and we have also added new devices specifically aiming at reducing the thrombus load. So the thrombus is more attacked now by new drugs and by new devices.
There is, of course, many permutations in the use of those antiplatelet agents, some of which have been tested. I mean, those permutations. It's perhaps a bit early at this stage in the life cycle of these new drugs to make a definite statement about which is the preferred strategy. I think we're still lacking phase 4 data. Obviously, the pivotal trials are very impressive in terms of improving the outcome, and we also have to recognize that ticagrelor is not registered yet. So
Yeah.
But I think for STEMI, maybe we could give a kind of a preference, because, I mean, we know for STEMI that prasugrel is more effective
There
than
is such a
clopidogrel.
superiority, yeah. I agree.
And there was no increased risk of bleeding in STEMI patients.
Correct.
So I think in STEMI there's a clear preference of prasugrel over clopidogrel, whereas in non-STEMI it's not so clear. But if you want to only stay with one drug for all the patients, which is difficult, but then if it's in STEMI superior and in non-STEMI it's equal, you can make a decision.
Yes, Sigi, but we should acknowledge that in STEMI we give a class 1 recommendation for all 3 drugs.
and it is great that we can use those efficacious drugs in those patients as well without increasing the risk of bleeding.
Okay, thank you. Thank you for your comments. I'm afraid that we have been very chatty, the 4 of us, as usual, I would say. This is the end of the program. I just want to thank the audience and summarize in just few words what we have said. We have a new set of guidelines on revascularization, not only percutaneous corneal interventions. These guidelines are very innovative, and we are very lucky because really good people have worked on this document for long, and if you go to the document, you will receive answers to many questions you may have, including pharmacotherapy. And I would say we are very lucky. It's true that the radar screen is very busy as regards the antiplatelet therapy, but the new drugs are so much more efficacious than the previous one, and we simply at the moment have to figure out how to best use them. So thank you for being with us, and maybe see you next year in Paris.